just wanted to say thanks for coming and sharing your story. It was an awesome story, and you're a great speaker. And thanks for all the work that you are doing for the patients.
Any other questions? The reason that the four of us are sitting up here now is we wanted to try to, again, bridge the connection. We are all here because of our patients and for our patients. And some of our jobs, mine specifically, some of our jobs focus around some of the more negative outcomes and negative aspects and areas of opportunity. And I asked, as I said, James Martimucci, our defense counsel, to be present tonight to participate in this because I wanted to draw the connection between the patient experience and what some of us think of as patient experience in HCAPS to examples like that we have on the back table back there of patients where we had opportunities missed or made mistakes, and they're not here to share this with us. So, Jim, could you speak a little bit to the connection and what you see in your experience?
Well, first, I agree with the comment from this woman in the back that there was a great talk that Tiffany gave all of us. I listened to it carefully, and I walk away with one main theme, and it really is all about communication. Quite frankly, what I do, by the time I usually meet you for the first time, unfortunately for you, it's because some type of claim has been filed, right? So that's usually not a very happy meeting for you. And then it is my job as the trial lawyer to persuade the other side that their position is not right, or if it goes so far, a panel, a judge, or a jury. My job is all about communication. It is the art of communication, to persuade an ultimate fact finder that the other side's position, that patient who's now become a so-called plaintiff, their position is wrong, our position is right. So when I hear all of this, and I've learned over the years what I do, it's an art, and I know the practice of medicine is an art. And now you're hearing tonight, I'm sure you've heard it before, the practice of communicating is an art as well. So as Tiffany said with some of the PowerPoints and her words, it's not simply bedside manner, it's not that simple. It's a way of communicating. Some of you may be sitting there saying, I already have a million responsibilities on my shoulders. I already have so much I have to do on any given day. I've been talked about, charting's been spoken to me a million times. I'm sick of it. Now I'm being told there's yet a new way to communicate. Well, maybe you're right. Maybe that is a little frustrating, but I can tell you from experience, it is very, very effective. And the studies have shown that if we learn how to communicate a little bit better, a little bit more productively, invite the patient into the process, lawsuits go down substantially. I'm not just talking about a little bit. I'm talking about substantially. So somebody asked, are there regions or areas of the country that this is being done a little bit better? I can tell you I travel all around the country, So I have more frequent flyer miles than you can imagine. And it's true, Tiffany said it right. There are pockets, I wouldn't call it regions, I wouldn't call it states. There are pockets where it's done really well. But I'll tell you one thing that's consistent across the country right now, absolutely across the country, and studies are verifying it. When you communicate better, openly, again to borrow a word from Tiffany, honestly with the patient, incorporate the patient into the plan, the lawsuits are falling off the table. Isn't that what you want? I mean, really what you want, number one, is good, great, quality patient care, right? What you want, and I'm not trying to be silly, is you don't want to meet me, right? Because when you meet me, that means something has happened. And now we are defending a claim. So instead of me trying to advocate more work for myself, it's the opposite. I would love to be more involved in the risk management conversations to prevent the claims. I'll just say one last thing because I don't want to be too wordy. I was recently in front of a jury here in Maine on a medical malpractice case. And one of the things that I always learn from juries, I always learn. So you're going to keep learning from your patients. I always learn from juries because after they render a verdict, whatever that verdict may be, I ask them, why did you decide the way you decided? Did I do anything that confused you? Did I do anything that offended you? Was there any one particular bit of evidence that was more compelling than the other evidence? I always ask that. The recent case that was so telling to me was a very, very difficult case involving an infectious disease. We had, both sides of the case, had experts from all around the country. Many of these experts had multiple board certifications in multiple specialties, the highest level of education at the best schools. And they spoke about amazingly esoteric things that no matter how many times I sat down with my expert before he and she testified and said, please try to communicate in simple words, it was almost inherently impossible. That jury decided in favor of my client, the doctor, because of another example that Tiffany gave about one of those things at the end, you know, what examples or suggestions would we do to Betty and the other patient? And she said, patients have choices, right? You can give a patient all the instructions in the world. You can tell the patient the medications that he or she should take, why they should take them, the occupational therapy they should undergo, why they should do it, the PT, why. They have a choice. They can say no. I asked one simple question of the plaintiff's leading expert at the very end of this amazingly confusing cross-examination that, quite frankly, I didn't even understand. And it was that. Doctor, one last question. Would you agree that when Mr. Smith left that hospital, he had the choice to say to himself, I'm not going to take that medication? And forgetting about his Harvard degree and his Yale degree and all certifications, he said yes. When the jury deliberated, they said they talked about that for 2 hours. The fact that the patient has a choice, and in that case, even though that patient died, because that patient didn't take a certain medication, it wasn't our fault. We communicated, we invited the patient into the process, and the patient's choice and decision was, I'm not taking the medicine. So I walked away from that and I thought, my client spent tens of thousands of dollars on all these experts. I could have found an expert so much cheaper in the state of Maine, an internal medicine expert that might have charged me $1,000, and I could have said, doctor, I'm just gonna ask you one question. The patients have a choice to say no to the medicine, it would have been the whole case. So you learn. People, juries are us, right? They're maybe not be as educated as you are. Most likely in a medical malpractice case are not going to have your training because we're not going to let a medical person on the jury. But they're us, meaning this, common sense. Most of the time, their decision is going to be based on what they understand and what their common sense tells them. So communication is everything. There's an art to it. You're not going to learn it overnight. The other thing I loved about what was just said earlier is you can watch somebody, right? So I think some people just inherently have that art and that gift of communicating. It's a great gift to watch people that have it. I think though you can learn it. I think you can watch a colleague that really knows how to speak to a patient, and when you see it, you say, wow, I'd like to do that. And you can learn over time to do it. But I'll say this, I will warn you or give you one unsolicited piece of advice on that. And it goes hand in hand with being honest. Don't pretend to be the other doctor. You know, if he or she or the nurse just speaks in a certain way, uses phrases that you would never use, but they're effective, and you think, wow, that's pretty cool, let me see if I can do that, you're probably not going to pull it off. Be you. Be honest. Be who you are, because that patient's going to figure out if you're being honest, and that honesty is going to give you so much better chance to connect with the patient. Here's the last thing, unless someone has a question for me. It's a little bit about the bedside manner. When I get involved in these cases, and I'm always trying to figure out why wasn't so-and-so sued? You know, I get the case, and let's use the infectious disease case again, and I see that the primary care physician was sued, the emergency department physician was sued, but I see there's another provider in that chain of care that clearly dropped the ball. Why wasn't he or she sued? You know what the answer is most of the time? The patient doesn't get it, but the lawyer, let's assume the lawyer for the patient understands. That provider did not get sued because he or she connected with the patient, and the patient told the lawyer, I'm not letting you sue that person. I hear it all the time. I've been in cases where there are multiple medical defendants, and all of a sudden in the middle of the case, one of them's gone from the case, dismissed, and it's not because they won the case in the middle of the case. It's because as the case has gone on, the plaintiff has gotten his or her kind of courage up and is going to the lawyer saying, I like them. They're the ones that talked to me. They're the ones that remembered who my spouse was, asked me about my kids, asked me how I was feeling. When I came into the room and my name is Jim, they didn't call me John. They said Jim. And they remembered that I had a kid in college, and they remembered what medications I was taking, and they remembered how the medications made me feel the last time. I do not want you to sue him. I hear it all the time. So communication is so key. It does take more time. It is a little bit more work, but the results are fantastic.
Just want to mention communication when things go wrong. People tend to be afraid to offer apologies to patients and to tell them the truth about what has occurred. And so that idea of being honest with patients sounds like a simple one, but when you're faced with a patient in a bed that has received the wrong medication, who is now having a serious complication as a result of that, how does that information get shared? I get calls often, do we need to tell the patient this because I think they're gonna be okay? How much should we tell them? And the kinds of questions that I get, people are trying to learn how to communicate that to patients. But statistically, I will tell you that patients who feel that we're honest with them, we're open with them, and we share all the pieces with them, they trust you. And they will, no matter how many complications they have in the hospital, if they feel that we will be honest with them and we are doing everything we can to provide a safe environment for them, they will stay here, they will come back to us, and they won't sue us. And we have been working really hard in risk management to help with the disclosure process and to move it one step forward and to help you to be able to feel okay with apologizing to the patient, telling them exactly how, when, and why this has happened, that we're reviewing that process and not hide anything from them, because you all know what happens when you're a patient and someone walks in the room and you know innately something has gone wrong. You know you don't feel right, something didn't look right, the pill was a different color, and you say, what was that pink pill I just took? I've never taken a pink pill before. And you're like, oh, that was just your anxiety medication. And you're like, I don't think so. And then something happens. You start to now develop that distrust in everything that the provider, the nurse, anyone does coming into the room. They second guess you. And then guess what? They don't come back. We lose that patient population. They then walk across the street to the attorney's office and say, something happened to me at the hospital. I don't know what it was because nobody would tell me. I need you to go find that for me. We have found that patients seek attorneys because they want answers and they need an advocate, and they looked to us as their nurses and doctors and whoever we are in the care that we provide to be their advocate. And when we don't advocate for them, when we're not honest with them, when we don't apologize to them, they go finding a lawyer who's going to do that for them. So it's really important that if you don't feel comfort in doing that, that you reach out to us, or you reach out to a provider, peer that has been through that process, and allow them to help you to be able to learn how to communicate that piece. It's very helpful. And as I said earlier, patients who do sue, I working with a family of a patient who has expired, and the husband came to me and said, I am only here because my wife asked me to follow up on this and get answers because nobody would listen to her. I have heard time and time again from families and patients, if someone had just listened and stopped and explained to me, I wouldn't be here. I would never have gotten an attorney, and I would not have sued, because suing somebody and getting an attorney is not something that I ever thought I would ever do in my life. So please take that opportunity to sit and listen to them and provide that information.
I just wanted to say that, we're with Jim and Beth, and a lot of Tiffany's talk was, encouraging you as providers and caregivers to take certain actions and change approaches to certain things you do. I want, to Beth's point, I don't want anybody to think that they need to do that alone. management is there to support you, reach to your colleagues, your team. Tiffany often referred to team and team steps. We are barely on the map as far as team steps. We know how to spell it, 2 P's. And that's about all I can say without lying. But with that, but we are moving down that road, okay? And so, but my point is the team that we have established and around the providers here may not be a team steps established process yet, and it's not that evolved, but we do have team and you do have resources. So feel free to reach out to anyone you trust, risk management, colleagues, administration, to help have these conversations, to work through these issues, because it is a team sport, and it very much, I don't want anybody to feel like they're out there and have to go into that room alone after an error, or go in and have a difficult conversation that they're not, comfortable having with a patient or family. Any other questions?
I just want to say one thing. You had mentioned earlier that these conversations can take longer. I would take objection to that. I would object. I think that while maybe some of the conversations would take longer, I think if we practice them, become strategic about them, become comfortable with them, they don't take much longer than the average conversation. And of course, on the back end, there's much less paging of the physician from the nurses. You don't have to deal with patient advocates. There's a lot, the process becomes more streamlined, and you're not looking at a lot of hands in a pie when the conversation is handled concisely and precisely. So I would say yes and no.
Last call for questions. Then I want to,
Just an observation of what Tiffany was saying. A big part of what's been frustrating me in healthcare, this is just, you brought up something, Tiffany, that a big part of what's been frustrating me personally in healthcare is this growing sense that the well-meaning quality and health patient satisfaction scores that are meant to improve quality is subtly, and sometimes not so subtly, putting the patient against the provider or the provider against the patient in ways that we really don't want to have happening. And it becomes very frustrating as a provider to be part of that process. And I know it's good to be strategic about your conversations, but I just want to say there's a basic joy about communicating with somebody well and just liking them and getting that established back again. So I actually revolt to some degree about making it too strategic and just saying it's nice to talk to somebody in the way you'd want to be talked to yourself, and really bringing it down to that level. And in all honesty, if my patient satisfaction scores don't change and I'm enjoying my conversation better and I'm getting better feedback from my patients, they will change, by the way. But it's brought some joy back because I'm very frustrated by a lot of this stuff. And I'm frustrated even by some of the way that we approach something that seemed to be so basic at one point in time, even when I started my career. And the simple joy of it has been more to me than all the other stuff. Either risk mitigation and all that stuff is less than I have a joy now at times when I'm with my patients that has come back again after not being there for a while, simply because I'm choosing to spend the time. And it's more rewarding than thinking I'm less likely to be sued, in all honesty.
so I'm going to allow that comment statement to sum us up, because that is I think that actually brings us full circle to the conversation we were having before tonight started, with the worlds of patient-centric versus physician-centric healthcare. And I think what Alan just described is a pendulum in the middle, where it can be mutually beneficial and mutually centric. So I want to thank each of you, and I also want to just note that the 4 of us up here it's somewhat arbitrary. We're here by job description and by role. We don't by any means have all the answers and all the, so if you have any suggestions or any ideas, please reach out and raise them up. We're always looking for new ideas. So thank you all very much for your interest and your attention and your attendance tonight. Thank you.